we're going to then move ahead. Dr. Lakkireddy is going to talk to us about left atrial appendage ligation as an adjunctive therapy for atrial fibrillation ablation.
Thank you, David. So we're going to keep it quick. These are my disclosures. So, this is probably a slide that's been showed by multiple people. So this, once again, takes us back to the embryological aspects of the left atrial appendage, the pluripotency of the cells that are inside the left atrial appendage. Oftentimes, the cardiac stem cells that are used in most of the clinical trials actually sometimes are derived from these appendages. And so what we really need to understand is, are these structures more arrhythmogenic than the normal atrial tissue? So we all probably have to agree that is probably the case. So if you look at that, the arrhythmia origin and the anatomic correlation of the left atrial appendage, why are these appendages arrhythmogenic? What makes them arrhythmogenic? So we know that they are trabeculated and they have extensive pectinate muscles. The varied array of the arrangement of the muscle fibers obviously creates enough of heterogeneity and the conduction abnormalities in this, causing a lot of reentry. Some of the automatic activity and the trigger focal activity that comes from these left atrial appendages is probably related to the arrhythmogenicity that you typically see in pulmonary veins as well. So this is a good example of what looks like an atrial tachycardia. Obviously, this individual was taken to the lab. The nice three-dimensional electron atomic map that was created here nicely mapped out to the left atrial appendage. As you see there, the electrophysiologist burnt the heck out of that, and the appendage did not really, the arrhythmia did not terminate. And so finally, they decided to call the surgeons. And they put in an appendage clip, and you see very beautifully that's where the tachycardia terminates. This is what you did. You basically created an ischemic infarct of the appendage, and then you excluded it both electrically as well as mechanically from the rest of the heart, and your atrial tachycardia got fixed. So, this is a nice, beautiful example of, you'll see the CT scan where you see the appendage being gone and ligated. So, and left atrial appendages are known to be notorious for atrial tachycardias all the time. This is something all the EPs deal with from time to time. This is a small case series from Kwang et al. There are 14 patients where the attack was automatic in nature, and 13 of these, they were able to successfully ablate it endocardially, and one patient required a left atrial appendage ligation because they could not get the tachycardia ablated with the radiofrequency ablation. And you see that most of these tachycardia seem to be coming from more distal aspects of the appendage. And similarly, there was another study that looked at the localized reentry within the left atrial appendage. When you take patients who have persistent atrial fibrillation, and when you follow the sequential approach to things, either the AFib organizes into a more organized attack, or they have a primary atrial tachycardia that you find along with active pulmonary veins, either during your first ablation or second ablation. And what was interesting was 19% of the 78 focal attacks they mapped in the LA, they all were from left atrial appendage. So focal micro reentry seems to be the most common mechanism in these people. And in almost all the cases, they were actually closer to the pectinate ridge that happens immediately after the neck. That sort of brings us again to the point where maybe when we ligate these appendages, we probably have to get the pectinate ridge included in it, thereby you actually get the true antiarrhythmic benefit from these people. This is another good example of a centrifugal activation of a focal left atrial appendageal atrial tachycardia, a nice three-dimensional electron atomic map. The earliest site of activation points to the left atrial appendage there. So this is actually a paper from Michel Hasseger's group. They did some very elegant pacing maneuvers to really show the entrainment process and prove the concept that they all come from left atrial appendage. So, and then this is data from Dr. Natale's lab. This is something that you all have heard yesterday. About 27% of the 987 patients that had focal triggers, they're all from left atrial appendage. And so this is again going back to the same concept of the arrhythmogenicity of the left atrial appendage, the focal origins of the left atrial tachycardias from different groups, showing the same thing. So when you isolate these left atrium, obviously you have focal triggers, and there is a dissociation of that, and this obviously translates into very proximate benefits of improved outcomes. I mean, if you follow them long term, obviously those patients who had left atrial appendage isolation, this is a very hard technique to do. I mean, I think of a lot of people that I know, Andre probably mastered this skill the most, and there are a lot of times I'm calling him, okay, fine, I'm here in this location, I burned a lot, but I'm not able to still get it. I think that's where the differential approaches of getting into the coronary sinus or identifying the Bachman bundle that is still attached to it in some of the angles, I mean, those are all the things that are necessary to understand this. So, okay, I think I clicked something I shouldn't be clicking. So what are the downsides of left atrial appendageal ablation or isolation? So oftentimes it's technically very challenging, and a complete isolation is not possible. Risk of perforation. I mean, you have seen Sam Asirwadan's pictures yesterday, all these little crypts. And I mean, they are paper thin. And any time when I'm telling my interventional colleagues about, we're ablating around the appendage, it's like, what the hell are you doing? I mean, it's just something inconceivable. But again, there are some inherent advantages, and it is a necessary evil that you end up embracing and live with it. Loss of left atrial contractility and its impact on emptying and stroke volumes is a big thing that we're all worried about, and thrombogenicity and the need for prolonged anticoagulations. The surgeons have also proven that you can actually create a beautiful exit block by surgical isolation using a clip. So why does it make sense to ligate the appendage in AFib? It's structurally the most non-homogeneous structure in the heart, and second most common source of focal triggers. And oftentimes it's only electrically active structure even in patients with significant atrial myopathy. There's a paper that we're putting out in this type of patients. Even though arrhythmia seems to be more paroxysmal, the only stuff that's happening is all in the left atrial appendage, an organized arrhythmia in the left atrial appendage. So once you isolate or electrically exclude this, you have a much better success. What does ligation do to the left atrial appendage? As we discussed earlier this morning, it becomes shrunk and becomes a fibrotic structure, and finally it gets eliminated both structurally as well as electrically. So what does it do to the left atrial voltage? This is a small study that we have done in our lab. This is the pre-lariat ligation voltage, post-lat with semi-occlusion, and then post-ligation after the injury current subsides, the voltage that you measure from the left atrial appendageal surface actually dramatically goes down. So what is the effect of the endoepicardial percutaneous left atrial appendage ligation on arrhythmia burden in patients with AFib ablation? This is a prospectively pooled data from 4 centers that we typically collaborate. We studied about 27 patients who had an implantable device, either a pacemaker or ICD, and then we followed them for about 3 months. And the arrhythmia burden decreased from 78 to 44%, clearly proving that there is some antiarrhythmic benefit here. To that extent, we started off a prospective registry called the LAA AF registry, assessing the impact of left atrial appendage ligation along with pulmonary vein isolation against AFib ablation. The prelim data is very promising. I mean, in persistent AF cases, 80% acute success rate, not actually 3-month success rate off of antiarrhythmic drugs against 45%. So that's pretty exciting stuff. Then you have the Watchman's with the simultaneous sequential AF ablation or simultaneous AF ablation. This is not only possible, but it's reasonably safe. This is a small data set from Karen Phillips' group from Australia looking at the feasibility and safety of it. I mean, this is something that I always believed in. I mean, this is something my teacher from high school told us. I mean, if you can't get what you want, at least improvise and continue to work on it. The power of imagination is immense, and someday you will succeed. So this is a little boy who wants to ride a Honda motorcycle, and this is what he did to his buffalo. So with that, we wrap up, and I would like to request the chairman to give us 5 minutes time to go over yesterday's case.